During a high-impact landing, the human lower extremity absorbs forces exceeding several times your total body weight in a fraction of a second. To manage this extreme physical stress without shattering, the leg does not act like a simple rigid post. The foot and lower leg form a sequential kinetic linkage, a mechanical system that dynamically adjusts to accommodate and distribute continuous force. At the top of this linkage is the talocrural joint, the articulation where the lower bones of the leg, the tibia and fibula, meet the uppermost bone of the foot, the talus. The superior surface of the talus is shaped like a wedge that is wider in the front. As the foot flexes upward into a position called dorsiflexion, this wider anterior edge jams tightly into the tibial mortise. This mechanically locks the joint to provide maximum stability right when the leg is fully loaded. Directly below that sits the subtalar joint. This lower joint acts as the engine of triplanar motion. When the heel strikes the ground, the subtalar joint rotates across 3 distinct geometric planes simultaneously, translating harsh vertical impacts into a smooth, controlled rotational glide. The physical locking of these bones provides a massive baseline of geometric stability, but maintaining perfect alignment under hundreds of pounds of shifting pressure requires a highly tensioned network of soft tissue to bind the architecture together. The first layer of defense consists of passive stabilizers. On the inside of the ankle sits the medial collateral, or deltoid ligament. This robust, fan-shaped complex has incredible tensile strength. It is specifically engineered to resist eversion, the outward rolling of the foot, and to prevent the ankle mortise from splitting apart under sideways valgus stress. The outside of the joint is secured by the lateral collateral ligament complex. Among its 3 distinct bands is the anterior talofibular ligament, or ATFL. Because the ATFL prevents the foot from sliding too far forward and inward, it absorbs the brunt of awkward landings, making it the weakest and most frequently injured ligament in the human body. Beyond these passive restraints are the active stabilizers. The primary dynamic support for the medial arch of the foot is a powerful cord called the posterior tibial tendon. This tendon routes down the back of the calf and hooks sharply under the medial malleolus, the bony bump on the inside of the ankle. Using this bone as a mechanical pulley, the posterior tibial tendon acts like a suspension cable, exerting upward tension to hold the longitudinal arch of the foot suspended off the ground. If these cables and ligaments lose their tension, the structural height of the foot collapses. The entire sequence of human walking relies strictly on this network holding the bones in precise alignment. Human walking is an oscillating pattern of controlled force accommodation and generation, facilitated by 3 distinct rotational axes known as rockers. The cycle begins with the heel rocker. At initial contact, the heel strikes the ground and the foot begins to pivot downward around the calcaneus. This phase is dedicated entirely to shock absorption. To prevent the foot from slamming uncontrollably into the pavement, the tibialis anterior muscle in the shin engages in an eccentric contraction. This means the muscle is actively lengthening while under tension, acting as a biological brake to lower the foot to the floor smoothly. Once the foot is flat, the mechanism shifts to the ankle rocker. The foot is now fixed to the ground and the entire tibia advances forward over the ankle joint. During this phase, the heavy calf muscles fire eccentrically. They pull backward against the shin bone to regulate the speed of the tibia's forward progression, controlling the momentum of the body's center of mass. Finally, the heel lifts off the floor, transferring the axis of rotation to the ball of the foot. This is the forefoot rocker, where the foot transforms from a flexible shock absorber into a rigid propulsive lever. To create that rigidity, the subtalar joint rolls outward into supination, locking the bones of the midfoot tightly together. Simultaneously, the upward bending of the toes pulls the plantar fascia tight. This mechanism, known as the windlass effect, dramatically stiffens the arch for power generation. With the foot locked into a stiff lever, the gastrocnemius and soleus calf muscles perform a concentric contraction, shortening powerfully to pull the heel upward and push the body off the ground. Efficient locomotion relies entirely on this flawless handoff of kinetic energy. The foot absorbs impact eccentrically in the first 2 rockers, stiffens, and unleashes that energy concentrically in the third. When the active suspension system fails, this handoff breaks down. The most common cause of this failure is posterior tibial tendon dysfunction, or PTTD. Chronic overuse causes the posterior tibial tendon to degenerate, elongate, and eventually rupture. Without its upward pull, the patient develops a condition called progressive collapsing foot deformity. This collapse happens across multiple planes. The medial arch drops completely to the floor. The heel bone tilts sharply outward into valgus. Finally, the forefoot abducts, sliding laterally to reveal the classic too many toe sign when the foot is viewed from behind. Because the heel is severely tilted, the massive Achilles tendon no longer pulls straight up. Its force vector shifts, pulling the foot further out of alignment rather than driving it forcefully into the floor. This anatomical collapse neutralizes the forefoot rocker. Without the tension of the posterior tibial tendon, the foot cannot lock into a rigid propulsive lever. It acts instead like a loose, disjointed bag of bones that leaks kinetic energy with every single step. A different type of mechanical failure occurs when the passive restraints give out. Repeated sprains to the lateral ligaments result in a condition called chronic ankle instability, or CAI. Patients with CAI experience frequent giving way of the joint, specifically fearing a mechanism of injury where the ankle rolls into extreme inversion, where the sole of the foot turns inward, while pointed downward in plantar flexion. To protect against collapse during movement, the central nervous system alters its motor control strategy. It preemptively stiffens the ankle joint just before the foot hits the ground, a compensatory mechanism known as intralimb reweighting. This chart shows the resulting shift in how the body absorbs impact. Because the ankle is held stiff, it generates significantly less eccentric joint power. To compensate for the lost shock absorption at the ankle, the body forces the proximal joints, the knee and the hip, to absorb a massive increase in eccentric load. Bypassing natural shock absorbers means the patient experiences excessive vertical and posterior ground reaction forces during the first fraction of a second of landing. Because the ankle is the foundation of the kinetic chain, its instability forces the entire lower limb to adopt destructive, high-impact movement patterns to stay upright. When the ankle's natural architecture fails, clinical interventions step in to physically block harmful motions. A common tool for this is the solid ankle foot orthosis, or AFO. By locking the ankle firmly at a 90-degree angle, a solid AFO provides external rigidity, bracing weak joints so they cannot collapse under body weight. But pinning the ankle at 90 degrees eliminates the ankle rocker, creating an abnormal extension moment that snaps the knee backward. To resolve this, clinicians add a rocker sole. This simulates the lost motion, realigning the force vector safely through the knee. In end-stage cases of disease, surgeons face a similar dilemma. Ankle fusion, a procedure called arthrodesis, permanently bolts the bones together to eliminate pain, but entirely sacrifices the ankle rocker. Alternatively, total ankle replacement implants an artificial hinge to preserve that crucial arc of motion. Successful clinical restoration depends on the precise, sequential execution of the 3 rockers. Simply stabilizing a loose bone or bracing a torn ligament achieves very little if the kinetic linkage remains permanently broken.